Okay, good morning, everybody. We're very excited to have you back and on a Friday morning. Just wanted to announce that we just got approval for you to request two software programs, BridgeWiz and GemCutter. So if you want to have those installed on your personal workstation, you can call the software request tool or email software request tool at itso.cdc.gov/SRT. And I'll just repeat that again. The Tuesday email, there's information in there about requesting two of the software programs, GemCutter and BridgeWiz, by requesting it through the software request tool website. EGLEA, which we went over yesterday, is something that is on we're working with CDC now to see if we can get a protected server, because that is a public website, and I know that if you're developing guidelines, you don't want them made public. So we're trying to see about options for getting a special server for that. But it is available, a hard copy, a PDF version of the spreadsheet versions of EGLEA are available on a PDF, and they are attached in that same email. Oh, it says attached? Okay. Okay. It'll be sent to you, the attachments for the PDF of EGLEA. Okay. Get that right? Okay. Okay. I'll repeat that. There's a PDF version and an Excel version of EGLEA, and you can have access to either one or both.
Good morning, everybody. Pleasure to be back. Yesterday, just to quickly recoup, we talked first of all about what's wrong with guidelines and what the IOM standards for better guidelines, aspirational standards for what constitutes good guidelines. We did an exercise with EGLEA where we identified obstacles to implementation. And then in the afternoon, we talked about building better guidelines using tools like BridgeWiz to incorporate the things that make guidelines better. Today, we're going to switch gears, considering that we now have access to high-quality guidelines, and address the issue of what do you do with high-quality guidelines, because just building them doesn't change anything in the world, unfortunately. So, converting guideline knowledge into clinical decision support. It may be more accurate to say into computer-based decision support, because it's both clinical and perhaps public health in many cases. But we're going to be focusing on what it takes to take knowledge that has been established in narrative guidelines and turning it into tools that actually influence behavior. So, improving practice is about improving care, and we are all about, all of us, improving care, either for populations or for individuals, probably not for microorganisms, I wouldn't think, no. 4 steps we're going to describe in knowledge transformation from the narrative guideline into executable computer-based decision support. I'm going to describe a clinical decision support tool that we developed at Yale that will illustrate several ways of providing decision support. The idea is not to get deeply into the clinical aspects of this, but to demonstrate that there's lots of ways to deliver decision support. And you'll recall yesterday we talked about action types in the setting of BridgeWiz as a place to help figure out what verbs were appropriate. Today we're going to use action types again to help define a design pattern for decision support tools. So again, I want to acknowledge ARC's contribution to our GLIDES project, Guidelines into Decision Support, and Yesterday I pointed out our partners who are guideline developers. Today, Yale New Haven Health, Yale School of Medicine, Nemours, and Geisinger, as well as Alliance of Chicago, where our partners have been our partners in terms of guideline implementation. We've taken, well, the GLIDES project had several objectives: to develop, implement, and evaluate projects that advance the understanding of how best to incorporate decision support into healthcare delivery, to explore how translation of clinical knowledge into decision support can be routinized and taken to scale to improve the quality of healthcare and delivery in the U.S., and what we focused on yesterday, recognizing the critical importance of transparently developed, clearly stated guideline recommendations for effective implementation. We have worked closely with guideline developers to improve guideline development. We know from several reviews, and you all probably know even better than I, that interventions to improve practice are limited. It can be very difficult to move from knowing what's right to having what's right actually established as practice. Education, conferences like this, although not so much like this, lectures, grand rounds, sessions, have been demonstrated in many studies to be fairly ineffective in influencing behavior. You can improve that somewhat by having the hands-on exercises and the interactivity that we have incorporated in this talk. But overall, education alone doesn't make much in the way of behavior change. Audit and feedback does a bit better. Seeing what people are doing, reporting back to them how they're doing, particularly in relation to peers, is a more effective way to improve practice. Financial incentives, and particularly disincentives, have been demonstrated to be effective if you have a certain threshold level of monetary incentive. 1% may not do it, 2% may not do it, and we're seeing more and more pay-for-performance studies. There was one just reported this week where they have demonstrated that changes in behavior were not forthcoming with the level of financial incentives that were offered. Patient-mediated interventions. Quit talking to the care deliverer and talk to the care receiver has been demonstrated in many cases to be effective, and as has computer-based decision support, which is what we're going to focus on today. What is computer-based clinical decision support? Systems that link health observations about a particular patient or population with health knowledge, generally expressed in those if-then rules that I keep trying to push on you, to influence health choices by clinicians for improved health care. There have been a whole series of systematic reviews of computer-based decision support, beginning perhaps in 1994, most recently in 2012, and they've all shown pretty much the same thing, that computer-based decision support often, though certainly not always, improves the process of care, and outcomes, which are infrequently measured, sometimes improve. So this tends to be a good thing, but it isn't an always proposition. Ken Kawamoto, writing in BMJ, tried to isolate features that predict success of computer-based decision support, providing that decision support at the time and location of decision-making, automatically providing decision support as part of clinician workflow, as opposed to making them go out and ask for some help, providing recommendations about what to do rather than just assessments of where we stand, providing periodic performance feedback and requesting documentation of the reason for not following recommendations if you decide you're not going to do what the computer suggests. So turning knowledge into clinical decision support, as part of the GLIDES project, we've identified 3 stages of process for converting knowledge about appropriate care into decision support. Knowledge synthesis, the combining of results of systematic reviews with the experience and expertise of guideline developers to create recommendations. And again, I want to re-emphasize that what's important is that systematic review. Perhaps not so much what you found if there isn't much there, but the fact that you did it and reported in detail how successful or unsuccessful it was. Knowledge formalization is an intermediate process where we translate these natural language recommendations into formats that computers can process. And then there's knowledge localization, introducing this transformed knowledge into systems that actually influence care, considering local resources, workflow, technical capabilities. All right, come on, buddy. There we go. So there are significant challenges in representing the guideline knowledge that we work so hard to create, to representing that in computer-based decision support. And in fact, in many cases, there's been kind of a black box between the published guideline and the computer. One of our goals has been to take that black box and to put it into a multicolored rainbow, to explode it into a process where we move from narrative guidelines through what's been called a semi-structured to a semi-formal approach, and ultimately to a formal computer executable approach to transmitting guideline knowledge. Why is that important? A couple of studies done now 15 years ago almost. Knowledge engineers at 3 very reputable sites, Columbia, Harvard, and Stanford, were asked to individually create clinical decision support from narrative guidelines they were given on immunization and for workup of breast mass. And they tested the clinical decision support systems that were individually created at these 3 sites by submitting standardized patients. The outcome, unfortunately, was that different recommendations were given for the same standardized patient at these sites. So that suggests that moving directly from those narrative guidelines, as perfect or imperfect as they may be, to a computer-based decision support system moving only through the mind of a knowledge engineer may not be effective, and we should probably have a more systematic process in moving from point A to point B. We can take knowledge about appropriate care and, using established processes, move to a narrative guideline, or perhaps using BridgeWiz as a crutch, we can move to a narrative guideline and make some judgments about how good that guideline is using instruments like AGREE or COGS, GLIA, or the Institute of Medicine criteria. The next step that we are suggesting is to move this narrative information, narrative guideline knowledge, into an intermediate knowledge representation that we call GEM. GEM is an XML, Extensible Markup Language construct, and the way we get there is through a tool called Gem Cutter that the folks here in the room will all be practicing with in a little while. XML allows the user to define his or her own tags for information. So, for example, if you put tags title around Gone with the Wind and author around Margaret Mitchell and an eligibility criterion around the text that says gross hematuria and tags describing evidence quality and put in grade B, we reach something that's certainly still very human readable, but it's also machine processable. And I'll show you what machines can do with an XML file in just a few slides. GEM, the Guideline Elements Model, is a set of 167 right now of these tags that are relevant to guidelines. That set of tags has undergone standardization 3 times, most recently in 2012. Another way to think of this tagging process is to use the idea of bins. If you have a bin called developer and another called purpose and another called method of development, you can select text from the guideline and shovel it into the relevant bins. Same idea as tagging. We're particularly interested in the recommendations bin. And in fact, each of these bins, but most particularly the recommendation bin, has bins inside. So there's a hierarchy. Recommendations include things like the conditions under which the recommendation should be fulfilled, the actions that are called for, the evidence quality, the recommendation strength, the reason. All of those things are tagged and represent bins into which you can shovel your guideline text. The way we do it, as I said, is with Gem Cutter. It creates an XML file, and I moved this slide early this morning, but let me just go a little out of sequence. When we created Gem for the first time, the guideline elements model, we were looking for what to name these tags. At that time, there were about 100 of them. And we scanned the health services literature, found that the health services literature had lots of ideas around the purpose, the audience, and particularly the method by which a guideline was developed. And we looked at the informatics literature, found it was kind of sparse around methodology, but very deep in terms of the knowledge components about how you would parse the recommendations. Well, what we did was we took all of these from the health services literature, from the informatics literature, and we called that Gem. Gem Cutter looks almost like this. This is one older version of Gem Cutter. There are 3 panels. You import into the leftmost panel the text of the guideline you want to mark up. In the middle panel is the guideline elements model in a list format. So we have here identity, which includes the title. And what we do is we simply select text. So for example, we would select this text for the title, recognize it belongs in the tagged element title, click a button, and it magically appears over here. And it also appears in this text box where the text can be modified somewhat. Also, definition for what we mean by title or citation or availability or status appears here in the lower right corner, or at least it should, and it will. Very good. Thank you. All right. The next step in this systematic process in moving from narrative guideline to executable knowledge is to make use of this XML file in various ways. And we have tools that have been embedded now within Gem Cutter that are called EXTRACTOR, that extract information from the XML file and restate it in hopefully useful ways, in ways that demonstrate statement logic, in particular, if-then logic. So let me just go. This is an extractor view of a particular recommendation. And along the left side here, you see some of the tags. Displayed next to the tag is the information that has been gleaned from the guideline. So, for example, evidence quality is grade D. The strength of recommendation is the expert panel recommends. The reason for this is treatment of young children is often in the form of a therapeutic trial.
The conference is now in silent mode.
And the conference is now in silent mode. Excellent. We have the condition, if there's no clear response within 4 to 6 weeks, and the actions. An action therapy should be discontinued, alternative therapies or alternative diagnoses considered. So we get all of these manipulated into a format that is different from, but certainly compatible with, the narrative guideline. The narrative had all of this structured in paragraphs. Hopefully it was all present. And we've been able to systematize it using the gem cutting process. It also puts the terminology, makes it available for us to choose structured vocabulary terms, coded terms, for the concepts that are represented. And I just want to go back to these. Another display that many groups have found useful is just to look at the decision variables, the conditions, the if sides of the rules, to see how many of these are findable in an electronic health record system. 0 to 4 years of age, 4 or more episodes of wheezing the past year, parental history of asthma. These are all if clauses. Some of them are immediately translatable into a structured vocabulary, and some of them are certainly going to need some work. Likewise, this is the if side. Here's the then side. The expert panel recommends daily long-term control therapy. Therapy should be stepped up if necessary to achieve control. By taking these out of context and putting them into a simple list like this, it often facilitates recognition of the fact that these are a little too vague, or that these are too underspecified, or they may be frankly ambiguous, and we need more information if we're ever going to be able to use them within an electronic health record system. The last step in moving from statement logic with coded conditions and actions to executable systems that are actually intended to interact with healthcare providers is a big step. And I think we may have been less successful than we would have liked over the last 5 years in trying to specify this step. We know it involves understanding local workflow and local barriers. It often involves taking national codes and retranslating it into local codes that work with a given system. It involves making choices of what decision support modality will be used. And we'll talk about this a bit in just a few moments. And it requires an understanding of human-computer interface design, so we don't wind up causing alert fatigue, where people, as soon as they see our hard-earned and hard-described knowledge, decide they're going to click right through it because it's just not important to them at the moment. The other thing that we can do, moving from this semi-formal stage where we have if-then coded conditions and actions, is to move to quality measurement systems. And this is something that Jeremy has been particularly interested in. Is it possible to automate or at least facilitate the process of moving from this semi-formal stage where we have a gemified file expressed in statement logic and move it into a file that uses a different system to encode performance and other quality measures? Question arises, how much of this knowledge transformation can be performed centrally by the guideline developers? It would be lovely if we could do the whole thing, but these local considerations generally mean that if we can get this far, we've come a long way, and we're not going to be successful in creating an executable system that people are going to be able to share in all likelihood, unless there's been careful consideration of these local concerns. Designing computer-mediated decision support systems. When people think of decision support systems, they're often limited in their thinking to, we must be talking about alerts and reminders, those things that come up in the course of documentation of a patient encounter that can be somewhat useful or can be simply annoying. But in fact, there are lots of other ways you can provide decision support at the point of care. A documentation template that reminds people what they should be asking. Putting that onto a template into which the answers get inserted at the time of the encounter helps to be sure that the right information is being collected. Algorithms or flowcharts, in many cases where you have complex logic, are very helpful. Order facilitators or order entry components that automatically structure a clinical order based on a set of findings that the computer understands about a particular patient have been demonstrated to be useful. Info buttons. For those people who want more information, there's a whole standard about how these could be developed and utilized, but basically what it amounts to is you put a question mark or a little I in the course of computer-based electronic health record documentation, and if you want to know more why, you push the button and it goes out and finds current references for you. Not necessarily old references that were put in at the time the system was developed, but really quite up-to-date filtered references that are applicable to where you are in the process of clinical workflow. Calculators, flow sheets, all of these have come to be considered part of decision support, where just a few years ago I think we were feeling somewhat constrained by only having alerts and reminders. I want to show you how some of these can be used by demonstrating an asthma decision support tool that we built. We used the National Heart, Lung, and Blood Institute's 2007 guideline on diagnosis and management of asthma. This guideline is 450 pages long, and it demonstrates a lot of the challenges that were involved in implementing recommendations for chronic management of a complex disease. This document is really full of tables like this, assessing asthma control in children 5 to 11, and then there was 1 to 5, and then there was 11 through adulthood, and there's asthma control, and there's asthma severity. There's a lot of information that's transmitted on these tables, but in particular, the NHLBI was interested in introducing some new concepts, specifically impairment and risk, and the criteria by which impairment and risk were to be defined. They were also interested in this most recent guideline in differentiating asthma control from asthma severity. So they had things that they were trying to put into the minds of their users, recognizing that these were new, innovative, and somewhat complex. Innovation in EGLIA that they would have had to check was a problem. So what we did was we took these tables and we tried to make similar looking tables in our computer-based decision support system. And you'll see that we used a heading of impairment and risk, and we talked about this being a template for judging asthma severity. We worked it out so that for these parameters, these frequencies could help remind you what to ask about, and at the same time facilitate your documentation of an individual patient's findings. So for example, we have these prompts for documenting appropriate information. We have real-time calculation and display. The impairment classification, as you click these radio buttons, changes dynamically, helping you to understand what constitutes moderate impairment and low risk in this particular instance. We have another page that is seen sequentially by a provider who's taking care of a patient. This page displays relevant past information, the severity and control assessments that happened at the last visit. And it prompts not just for collecting the information like we saw on the last page, the information necessary to trigger a rule, but it prompts you to describe what it is you're seeing. And it provides an alert. Based on the information that was provided, this suggests that the severity classification is moderate persistent And the recommended therapy is what is called step 3 or 4, along with regular follow-up every 1 to 5 months. That's presented as a dynamically generated alert. The clinician is free to accept that alert or to reject it. If they reject it, we ask them to describe why. If they accept it, they click on one of these steps, 3 or step 4, and in fact we're reminded about what constitutes step 3 or step 4 therapy, in case the clinician has a hard time, as I certainly do, remembering what the components of step 3 or step 4 are. Finally, once you've selected step 3, an order set is automatically generated. And in this case, for step 3, quick relief medications and long-term control medications are made available, and we facilitate the selection of these medications by just having a button if there's a new order or this is a refill. The idea is to make the right thing the easy thing to do. And in addition, the very last page provides a customized and customizable handout that takes information that's been entered by the clinician and puts it into the red, yellow, green zones for patients recognizing how severe their asthma symptoms may be. We also automatically generate a medication authorization, which is particularly useful for pediatricians taking care of kids who need this at school and after school care, and another for camp. So the idea of all of this was to make decision support integrated into workflow and something that providers would find useful and would not try to avoid. Now, let's talk briefly again about action types. You'll recall from yesterday that there are these 14 actions that guideline developers are pretty much limited to as they make guideline recommendations. If you're doing a test-style recommendation, there are a number of considerations that you may want to design into your system of decision support. We're not just talking about what happens on the computer screen, but there are whole systems of decision support. Whenever there's a test, whether it's for dyslipidemia or something as complicated as an adrenal biopsy, you may want to display test information for clinicians and patients, display the indications for doing the test, present test options, display somehow the recent results from the same or related tests, show test costs. These are things that might be part of a decision support system where a test is called for. We may look for assistance with scheduling, requiring what are the requirements for patient preparation or collecting the specimen. We might want to offer interpretation aids. What is the sensitivity, specificity, predictive value of this test? The reasons for false positives or false negatives. What are normal values for age, race, and gender? We might want a tickler follow-up system. We know that the results of this test aren't going to be available until next week. How about you get a reminder next week to go check on that test? And it's probably useful to have some coding information if you're going to bill for this test. Each of these things is a consideration that you may want to build into your system as you're creating decision support around a guideline recommendation that calls for performing a test. Likewise, when you have a guideline recommendation that calls for prescribing, you may want to present drug information to the clinician or the patient. You may want to display safety alerts, provide dosage calculation assistance, and provide corollary orders. You're prescribing a new anticonvulsant. You want to remember in 10 days that you want to measure liver function tests. Performing a procedure. The idea is that the action types can suggest patterns of components that may be useful in a decision support system. So one of the things I'm going to ask that you do, as we go through the tonsillectomy exercise, and we look at the one recommendation, is I'd like you to think about what kind of recommendation that is, in addition to marking it up, and what might be a way to design, what's involved in designing a decision support tool to promote recommendation 1 of the tonsillectomy guideline. So, in summary, we have talked about improving practice being our goal and how just creating guidelines doesn't achieve that goal. There are 4 steps in knowledge transformation, at least as we envision it using GEM as an intermediate knowledge representation. Clinical decision support is more than alerts, and action types can help facilitate CDSS design. I think that's what we've got for the morning. And now I'd like to open it up for questions. Yes, and you'll see it in action in a few minutes as you do it yourself. The question is, can I be clearer about how we move from a narrative guideline to semi-structured text in the guideline elements model? Specifically, with regard to, well, let me take something simple like the title. The title of the guideline exists in narrative text. You select that text and decide where in the GEM hierarchy it belongs. It belongs with tags around it that say title, and you'll find that in the middle panel of GEM Cutter. You click there and hit a little triangle button, and the text of the title appears there and is known and is then understood by the computer to be the title of this guideline. Likewise, the conditions of a recommendation, the if side, are moved by selecting them and moving them into a component or multiple components called decision variables. The actions are selected and moved into tags that say action, and we display them later by selecting a display report that puts an if and a then in place. So the computer is not really very smart. Unfortunately, it is the marker-upper who is smart. So the question is, can GEM Cutter be used? I think what you'd like GEM Cutter to do is to be the decision support. And I want to reframe this that will hopefully make it clearer. The decision support tool that you would like to have runs on rules. It runs on if-then statements. And we have to somehow get to if-then statements from the flowery, lovely text that our guideline developers have published in boldface type. GEM Cutter systematically takes that text, parses it, dissects it, puts it in labeled bins, but it doesn't decide what ultimately to do with that parsed text. The parsed text is up to decision support designers. So it creates an intermediate representation between the narrative guideline and the decision support system that you'd really like to have. So you've developed, ACIP has developed decision support to help with the childhood immunization schedule. And this is a particularly difficult set of rules. Those rules are really complex rules. You would think if the child is 2 months old, he needs A, B, and C. It used to be like that. I practiced pediatrics when it was like that. So resource constrained as we are, this question is, particularly with respect to time, what has been our experience in people using the decision support tool? Mixed. Specifically, we implemented this system at Yale, was also implemented at Alliance of Chicago, more effectively, in fact. But let me tell you the Yale experience. We did it at Yale in 2 clinics, a pediatric pulmonology clinic and in a primary care clinic. The pediatric pulmonologists have been a tough group to get to use this while the patient is in the room. They feel that it interferes with the doctor-patient relationship. They feel that they should know this anyway. They feel that this is not necessarily a tool that is important for them, in spite of the fact that 2 of the pediatric pulmonologists were very actively involved in the design of this system. So on the other hand, the primary care docs have been very happy with it and use it with some regularity. We have kind of a 50-50 split among our primary care docs, and these are primarily residents. There are those who are really very facile and comfortable with using a computer while the patient's in the room, and an equal group that are less comfortable with it. But one way or the other, they need to do their documentation while the patient is still here, or all that decision support is worthless to them. I'll tell you briefly about a study we did where we looked at the pediatric pulmonologists who didn't think they needed the system. And we compared what they did with what the guideline called for. In 90% of cases, give or take a percent or 2, there was complete congruence between what the pediatric pulmonologist did and what the decision support tool was calling for. In about 5% of cases, the decision support tool was not quite right. The reason for the cough was not asthma, and therefore the pulmonologist understood something that the system didn't, and called for alternative treatment. However, in another 5%, the remaining 5%, there was agreement between the pulmonologists and us that the care that was provided would have been better had they followed the decision support. So 90%, 5, and 5. That's the way we're hopefully moving. But a lot of people are not facile with the computer, no matter how long they've used it. We've just made a change from the system that I showed you, which was the centricity system, to the EPIC system. And in making that change, we've lost all of our decision support. It's going to have to be rethought and hopefully re-engineered. But we have a sub-project trying to get the pediatric pulmonologist to use the system while the patient is in the room. We gave iPads to the patients while they were waiting in the waiting room and asked them to fill out the frequency for each of their symptoms. So those questions didn't have to be asked. We did it in English and Spanish so that Spanish-speaking patients could fill it out in Spanish and the answers would appear in English. This information went wirelessly into the clinical decision support tool that was available in the room. And in order for the docs to see what the patients had written, they had to open up the decision support tool. So we did get them at least to look at it while the patient was in the room. But it was sneaky. So the question is, how do we deal with vagueness at the time that we're developing decision support tools? And this is a terrific and unanswerable question. It's the reason why informaticians are interested in guideline development. Until you have specified a statement clearly enough that a computer can understand it, you're not going to be able to deal with that statement. So there has to be for these vague statements, at the time of implementation, there has to be some interpretation that goes on. And, and the question is, how does that process happen? Who's the person who's doing the interpretation? Is it a subject matter expert, or is it somebody, a knowledge engineer with theoretically dual expertise in medicine and computers? Or is it purely an IT person in some instances who has to make a judgment that, you know, there's no difference between those two ICD codes as far as I'm concerned, so I could pick either one, when in fact there is an important difference. The whole purpose of being a major purpose of our being explicit and careful about what these bold-faced recommendations is we don't want the wrong person to be making interpretations that go into decision support tools. So that gets into the level of obligation that these systems impose. When you have, for example, a weak recommendation or maybe a vague recommendation, excuse me, you certainly don't want it to really impede the process of care. You may want something off the center of the screen to appear that is informational, but you probably don't want to stop somebody in their tracks, like a guideline recommendation that says if a patient is allergic to penicillin, then don't use anything from the penicillin class. If you had that if-then rule, you would design a system that really made people stop and take notice. They wouldn't be able to select penicillin if penicillin allergy was part of the patient's history. The only way around it would be to call an infectious disease expert who would approve it, for example. That's a full-stop, strong recommendation, very different from what do you do with an informational, weak recommendation. And there's a whole series of levels of interventions that can be designed into your decision support tool. Is that fair? I'm equating strength of recommendation with vagueness of recommendation, because in many cases I think they're closely related. But I think from a decision support developer's point of view, they're equivalent. So I just want to repeat this while it's fresh enough in my mind. The questions go on longer than my memory does. That you see a value in this approach for community health interventions, not just for patient-directed interventions at the point of care. Is that fair? I absolutely agree with you. I'm still having difficulty seeing where public health interventions, at least at a high level, are different from these clinical interventions if they can be specified as an if-then rule. That's the intermediate representation that I think most often is useful for designing an implementation system. For that environment, are we working with anybody at present? No, we would be delighted to. Invitations gratefully accepted. And Tamara? So there's a discussion going on that this is already in progress for immunization, specifically for flu and for Group B strep treatment. The whole immunization schedule, not simply influenza. And I still interest on about how this might work, not just at the patient level, but at the community level. And I think it depends on what your rules are at the community level. So the question is there utility in using a system like this for putting narrative guideline knowledge into a format that not just computers can understand, but might be usable for creating wall posters or other tools that would be valued by clinicians? I think absolutely. and those wall posters go a long way in many settings for helping people decide what is appropriate. The immunization schedule is probably hanging in every pediatric office in the country, for example, even though we don't have the electronic decision support system available. I suspect that daily the people who are administering immunizations are going to that wall chart to decide what's appropriate in this particular instance. Okay. In the process of creating flow charts, it's been noted that many times the logic seems to change and certainly is clarified. The process of building flow charts for decision support around any particular issue helps to clarify that issue. I just want to add one point, and then I think we're going to one of the uses that we have proposed for gem-cut guidelines is to make the information available over the National Guidelines Clearinghouse, to have as part of what's delivered from NGC, not just the abstract of the guideline, but a downloadable gem-cut if-then set of recommendations. We've been frustrated that ARC has not seem to have sufficient funding to do this, but there's a new funding cycle that's coming up this summer, and we're hopeful that this may be part of the NGC offering, a standardized output from NGC for all kinds of guidelines that they develop there. All right. On that note, I'm going to pass the headset.
Okay, so for those of you on the phone, thank you very much for joining us. In just a moment, you'll be getting an email directly from me with the evaluation form reattached for you and some information about accessing GLIA in paper form. And I will send that out to you in just a moment. The rest of you here in the room are going to start a hands-on exercise. Thank you.